Okay, great. Okay, good morning, everyone. All right, welcome to our January rendition or session of our Osher Center for Integrative Health Grand Rounds. And Happy New Year to everyone. Hope this year is off to a wonderful start. My name is Darshan Mehta. I'm the Medical and Education Director for the Osher Center for Integrative Health, and it's really my joy and privilege to be here to be with all of you this morning. So as people are gathering into the waiting room, I just wanted to just share a couple of, gathering into the audience, I should say. I wanted to just share a couple of announcements. Let me share my screen here. All right. So today we're really honored. I'll introduce our speakers in just a moment to have Dr. Jay Luthar, Dr. Carolyn Bernstein, and Dr. Lina Hudson guide us in a discussion on treating chronic post-concussive headaches through the fascia. And I'll introduce them in just a moment. Just as a reminder, we encourage you, for those of you who are able to participate in taking part in the Osher Pilot Research Grant Program. Our 2025 funding cycle is open and the letters of intent are due January 15th. We set aside about $120,000 available for seed funds for up to 4 collaborative projects. And the themes that we encourage include the science of mind-body connections, the clinical effectiveness of multimodal integrative health interventions, systems and translational biology and integrative medicine and health, the science of human and nature connections, and then lifestyle, nutrition, and dietary supplements. The QR code is there, so feel free to go ahead and scan it if you want more information, which is on the oshercenter.org website. For those of you, if you're requesting CME credit for today's session, we do offer a CME credit through Harvard Medical School for participation in today's grand rounds. The email address is hmsoshercenter@bwh.harvard.edu, and please provide your full name, your degree, and institution. We are in a webinar format, so just as a reminder, we encourage you to put your questions in the Q&A box that's in the which you'll see in the form down below, and we will curate them and then ask them to our audience. Okay. And with that, and then just as a reminder, and I'm going to go back to this again at the end, our February grand rounds, which are on February 4th from 8 to 9. It is going to be on integrating whole person care, a mindfulness-based model for Parkinson's disease and care given. And this will be done by Dr. Jojo Kwok from the University of Hong Kong. So more to share again at the end as well. Okay. So with that, it's really my joy to introduce my colleagues here. Dr. Jay Luthar is a primary care physician who is starting an integrative concierge practice in Back Bay entitled Soma Health. He delivers personalized care for both chronic and acute conditions with a strong focus on lifestyle and mind-body medicine. He's an instructor and medicine at Harvard Medical School and teaches in the physical diagnosis and reasoning course and maintains an appointment at the Brigham Women's Hospital. He also mentors fellows in the Osher Collaborative Fellowship Program in Integrative Medicine. Dr. Carolyn Bernstein is a neurologist, double board neurologist and headache specialist, and is the Levine Family Endowed Chair in Neurology. She's the incoming chair of the American Academy of Neurology, Neurohealth, and Integrative Neurology section, and practices whole person headache care at the Osher Center for Integrative Health at the Brigham. She is an assistant professor of neurology at Harvard Medical School. And Dr. Lina Hudson is a doctor of physical therapy working independently in Back Bay. Lina incorporates Eastern theory with traditional Western physical therapy. She integrates both with needling and the Stecco model of fascial manipulation. Lina's practice is 360 balanced physical therapy and she can also be found at Sollus Unified Health, a practice that focuses on the human fascia system. So with that, I will turn it over to Dr. Luthar.
Thank you, Dr. Mehta, and thank you to the Osher Center for having us here, and to Dr. Bernstein and Dr. Hudson for doing this with me, as well as our patient Nicholas for joining us. So let me just get my slides pulled up. All right, so this presentation is entitled Treating Chronic Post-Concussive Headaches Through the Fascia. And just some disclosures, I have no conflicts, Dr. Hudson has no conflicts, Dr. Bernstein has some research support from a few companies here and does some consulting. So overview, I'd like to just review concussions, the pathophysiology of this medical condition, review our patient's case history, discuss the diagnostic criteria for post-concussive headaches and think about a differential diagnosis for what may be going on. Learn a little bit more about the fascia and its role in pain sensitivity, inflammation, and review some of the literature on fascia-based or other manual therapies for headaches and think about how this might be a new way to think about treating some chronic pain conditions. And so I'd like to introduce my patient, Nicholas. Thank you for being here. So, Nicholas, you came to me as a primary care patient, recently moved to Boston, law student, and overall healthy, but you had two concerns, and one was a strong family history of cardiovascular disease, which will be another case topic. But the most pressing thing for you as you're starting your graduate program was this chronic daily headache that was really interfering with most of your life, right?
Yeah, that was the big one that was going unsolved.
Mhm. Oops. And you had this passion for horse riding since you were a child. And it seems like the main issue behind all these headaches that you were having was repeated head injuries. Um, and so let's walk through some of that a little bit. So let's just go through your concussions here. So Nick, just walk me through this a little bit.
Yeah, so the first time I even learned what a concussion was in sixth grade, and I was playing with basketball, indoor basketball with some of my friends, and I tripped uh, probably a block and got hit and thrown into the cinder block wall back of my head. And I didn't really know much about concussions at the time, but I was out for about 2 weeks. Um, Classic concussion symptoms, dizzy and all that. And then between sixth grade and 12th grade, I suffered six further concussions, so seven total, but three pretty big ones. The first one, and then in the junior year of high school, I had a robotic horse, which is funny enough. It was a service to learn how to better protect yourself when you fall off a horse. Because I did eventing for a long time, which is where you're you know galloping horses over fences out in the field. So occasionally, you and the horse might go down together. Um, I failed to learning how to fall off the horse properly and ended up with a pretty bad concussion. And then my final one was actually on the horse, my beginning of my senior year in August, and the we were going over a fence, and my head slammed into his head, and we met. I met him at the pole of the horse's head, which is where their head meets their spine. It's the single hardest bone in their body. And I'm not sure if I was unconscious. I do know that my body like slumped over and I was very irrational. And from that moment on, I suffered constant headaches and never really was the same in terms of sleep, pain, and overall uh, general day to day health, I guess you could say, like quality of life.
Yeah. And you were wearing a helmet in this impact, right?
Correct. The helmet is what actually hit the horse first, yeah, but it was just the what I've come to learn is that it's not really about the impact itself, it's what occurs internally, the jarring of the brain inside.
Exactly. The helmet will prevent skull fracture, but the concussion itself is coming from what's happening within. So let me walk through a slide on that a little bit. So a concussion is basically a mild traumatic brain injury in which the brain is experiencing rapid acceleration and deceleration. In very severe cases, there can be bruising, but in most cases, you're not going to see anything on imaging if you did an MRI or a CT of the brain. But what's happening is all the axons in the brain, all the different connections between the neurons get stretched and pulled apart and brought back together because of this rapid acceleration and deceleration. As a result of that, there are blood flow changes that are happening. The energy metabolism of the nerve cells um, end up having problems. There's some chronic inflammation that can happen. And this whole constellation of phenomenon leads to the subjective experience of the patient, which can be pain in the form of chronic headaches or neurosensory deficits. You mentioned brain fog, some dizziness, difficulty sleeping. And this can happen both in the acute phase during the concussion itself, as well as lingering symptoms in what's known as the post-concussive phase. And, this was quite disruptive for your life. The final head injury in 2018 basically set up a situation where your school, your social life, just your quality of life overall was constantly impacted by the headaches, right?
Correct. I actually had to stop riding horses after um, I tried to continue for the rest of my senior year of high school. And when I started that summer between high school and college, I made the decision that it just wasn't in my best interest to keep living with this pain and
Mhm.
this risk of further pain.
Right. One thing that can happen with these repeated mild traumatic traumatic brain injuries is that every time you have the next one, it just makes the neurons in the brain more susceptible to more injury. And that was a difficult decision for you because this is a passion of yours, right? You love horse riding.
Yeah, no, I probably before I could walk, I was on a horse. So yeah, it was not easy to determine that was what was in my best interest because my heart said it wasn't, but my body said, yeah, probably should give it a little break.
Yeah, yeah, that was hard. Um, but you ended up going to college, and what you described to me is that on a daily basis, you essentially had this kind of headache radiating to your forehead and eyes from the back of your head. And at best, it might be a 4 out of 10, but a lot of the times it was like debilitating, 9 out of 10.
Yeah, it was just constant. And then when it was a 4 or 5, you were like, oh, this is a win today, even though it really wasn't. I mean, after like the first year and a half, you start to get numb to it and you start to think that this is just what life looks like.
Right? Chronic pain can just be so difficult, and the adaptations people will have to make to cope with it. I think you were facing some of these things. And so obviously you sought medical treatment. You did everything from over-the-counter pain medications. You saw specialists and you were given medications like gabapentin. You tried steroid injections. You had done a round of, actually a couple of runs of traditional physical therapy. Um, but tell me a little bit about some of these medications. I don't remember them being very effective for you.
No, I would say over the counter was mostly Tylenol and Advil, and that would get you to be able to be functioning for maybe an hour, 2 hours at a time, where you could go to class and maybe take a nap or something like that. But it wasn't, it was just taking the pain from, say a 9 to a 4. The gabapentin, that that was an interesting one because I felt mostly the effects of like you have no feelings. You're just kind of numb to the world itself. I think I got most of the um, comments that were like from my family and friends was, "Hey, you kind of just seem no energy, kind of dull to everything." And it
Mhm.
kind of solved the pain, but was that really an answer of maybe of a little pain and but you don't really enjoy anything else? Steroid injections, those were awesome. They lasted 3 weeks of pretty much pain free, but can only get them 3 times before they said it would cause more damage to continue to inject the occipital nerves. Um, but for probably 3 weeks, it was pain free. I could sleep for the first time. Like I would get the injections and be able to sleep a full night's sleep. And then it would just come raging back um, like 3 weeks later. Physical therapy, uh, that was the constant. Like, hey, if you keep trying, maybe something will happen. Like we're going to build up other muscles around it. take some of the pressure off your neck. Just kind of, I was doing other things, working out other muscles and feeling like I still have this pain, and I'm just, spending 3 times a week, 2 times a week doing something that's not helping me.
Mhm. Yes. So by the time you came to me, you had been dealing with this for about 5 years.
Yeah.
And after going through so many referrals and specialists, treatments, you were like, maybe there's a surgical denervation. Somebody mentioned to me back in Kentucky where I was at, can you please refer me for this? But you also mentioned that after the initial injury, people were talking to you about your issues, but you hadn't really had an evaluation, like a physical examination of your head and neck. So I thought maybe it's prudent for me to do this before we decide, on a surgical option. So I sat you down and I had you move your neck left and right, up and down, and very obviously your cervical range of motion was very limited. And then I got my hands and I palpated your neck, and the tissue was quite firm. You had many knots, you had trigger points that I could palpate, and some of them I remember you say, well, this kind of reproduces the intensity of the 9 out of 10 pain when you press on this spot. But the rest of your neurological exam was normal. Does that sound about right to you, Nick?
Yeah. And what's worse is, you don't even realize you have that limited range of motion until someone tests it out.
hmm hmm So I thought, okay, before we jump on the surgery, I think what may be happening is that there's a dysfunction in the myofascial system between the muscles and the fascia, all this connective tissue that connects the body and is responsible for some of the biotensegrity of motion and structure. And just a little aside back into anatomy, Dr. Hudson will talk a lot more about fascia and some of the science and research on that, but fascia really impregnates the entire body. And if you look at this anatomical picture of the skull, there's the falx cerebri and tentorium cerebelli. And this is actually a fascial structure that one of the roles that it has is to protect the brain, including from strains from forces in head injuries. And this fascia in the skull actually connects to the cervical dura, which is a type of fascia around the cervical spinal cord at the level of the foramen magnum of the skull. Around that same part of the skull is something called a myodural bridge, which is a sheath of connective tissue that connect the suboccipital muscles to that cervical dura. And all those muscles are innervated by the first cervical nerve, dorsal ramus. And so here's a photo of what I just described. On the right, you can see these are some of the suboccipital muscles. This is that myodural bridge. This is the dura here that's connecting into the skull, which will connect to the falx cerebelli and tentorium cerebelli. And then this is a picture from an anatomical textbook on trigger point pain referred patterns, which mimics this. And this is almost exactly what your pain was, right? If you look at the red dots as the intensity of the pain coming from here
Yeah,
and radiating to the front.
correct.
So this textbook, was from 1970. So this has been known for quite a while, actually, the science of fascia and trigger points. And this is the textbook that I'm referring to, the Travell, Simmons, and Simmons book. It's a good book. And there's a lot of other research on fascia and concussions and headaches. And so I just wanted to highlight a couple interesting studies I came across. So this study here, they use an ultrasound device to look at the cervical suboccipital muscle areas of people with occipital neuralgia, which is a type of headache syndrome similar to what Nicholas was experiencing in terms of symptomatology, migraines, and then people, who didn't have headache conditions. And what they found is that in the people with the chronic headaches, there was actually an increased thickness and fibrosis of the fascia itself. And some of that inflammation and fibrosis actually was entrapping or encroaching on the suboccipital nerves. Makes sense why Nick was having some short-term relief with the steroid injections around the occipital nerves, because probably he was experiencing this type of inflammation and fibrosis in the fascia. I wish we had an ultrasound of his neck before and after, but next time. And then another study showing that in post-mild traumatic brain injuries, the suboccipital muscles are showing some fatty degeneration and reduced volume. And the more dysfunction in the suboccipital muscles, the slower the recovery in these MTBI patients. And then there's other studies on the role of cervical spine dysfunction in post-concussive symptoms as well. And this research kind of is theoretical, but then the practical result, I said, I know a really good physical therapist, Dr. Lina Hudson. She works very much in this myofascial therapy. So why don't we have you see her? And then with that, I'll hand it over to Dr. Hudson.
Thank you, Dr. J. I'm going to go ahead and share my screen here. All right. So that is true. We actually worked on the fascia of in Nick's case, and the model that I use is the fascial manipulation by Stecco. But before I start with the treatment, I would like to talk a little bit more about what is the fascia, right? So the fascia is a connective tissue sheath or envelope that covers our nerves, like the epineurium, muscles, epimysium, and organs like the pericardium. Now, how does this fascia work in our body? It actually transmits mechanical tension to stimulate muscle spindles and Golgi tendon organs that are embedded in the fascia and muscle tissue. Thus creating proprioceptive sensory and autonomic feedback peripherally coordinating our movements. And so in some cases, what does it mean when we have a dysfunctional fascia? So first, the mechanical stimulation that we talked about, it depends on the mobility of the fascia or the ability to slide among the adjacent structures. And we call it the gliding of different fascial layers all the way down to the adjacent structures, which can be the muscles. The mobility of the fascia is dependent upon the fluid matrix in the interstitial space between the fascial layers. Because it is known that we have the superficial fascia and then the deep fascia. And in the deep fascia, we have several layers, which are mostly 3 layers before we reach the muscle. And so this interstitial fluid matrix can solidify under various forms of chemical and mechanical stress, limiting the fascia mobility. In Nick's case, the blow to the head or the concussion that happened, that was a mechanical stress that also caused a chemical stress, and that might have caused a limitation in the fascia mobility, and so the gliding of the fascia. And so a fascia that cannot move, it cannot pull on the Golgi tendon organs or muscle spindle, creating a proprioceptive and autonomic dysfunction and pain perception. It is good to mention that the fluid matrix is very rich in hyaluronan or hyaluronic acid, which we are familiar with, and it goes into it in this adhesive state and is unable to stimulate the Golgi tendon organs or muscle spindle. We have a good, here we can see the, on the right, how the fascia disorders can create muscle dysfunction, altered proprioception, pain perception, muscle stiffness, and muscle weakness, which what we actually saw in Nick's case. And so we go back here to, this is the fascial manipulation by Stecco, the treatment that I use. What is it? It is basically a systematic manual approach to restore this fascial mobility that I was just talking about in areas specific to the spindle or GTO. So they basically dissected fresh cadavers and not drained and embalmed cadavers, because in fresh cadavers, we can actually see the hyaluronic acid. And the fascia. And so they dissected the fresh cadaver to locate those muscle spindles and Golgi tendon organs. And so they mapped a continuous lines of fascia across the muscles and the joint. And so these lines of fascia, they were organized by plane of movement that each line of tension would affect. And so in this treatment, we try and identify which line of fascia is affected in each person. And so once I can identify this fascial line, I'll be able to go ahead and palpate the points along the line. And those points can be very painful. Those points can radiate or recreate the pain symptoms that the patient has been feeling. And so the treatment consists of just friction and enough pressure of the point that will increase the temperature of this point or the area locally by 102 degrees Fahrenheit. And so the key of this treatment is to turn this hard hyaluronic acid or the adhesive hyaluronic acid into a watery-like consistency so that we can restore and promote the gliding between the layers of the fascia and the visceral fascia. And so Dr. J already talked in details about the history, but in my case, what matters for me in Nick's case is that his history was important because I wanted to understand the mechanism of injury, and because a fascial line can be affected not locally but distally. And so a blow to the head can create a direct trauma to the head, right? But there's lots of indirect traumas along the line or along the body. And so a direct trauma affects the fascia locally, like I said, and along the line. And so, for instance, here the red dots are the painful spots that I found in Nick's case. So we had lots of pain in the neck, very true, but the pain was also, the points were also showing some signs of radiating pain and along the neck, chest, torso or trunk, and the upper limb. Actually, all the way down to the lower back too. That was interesting as well. And so I'm just gonna ask a little bit more, Nick, why don't you describe briefly your symptoms when you first saw me on the first visit?
So the first time it was, the 9 out of 10 pain, constant pain, and the unable to really function day to day with the headaches.
Mm-hmm, mm-hmm. Yeah, and so this is where we started talking about how it first started, and the series of concussion that you had, and the most recent one in 2018 that actually made you feel this constant pain. And so after we talked about this history, I was able to a little bit have a better, let's say, idea of where should I start palpating? How can I start my treatment plan? And so we first started with palpating your neck, and in this case, the red dots. Those are the points that I palpated. And so after the first visit, you didn't feel tons of relief, but tell me, how did you feel after the third visit?
After the third visit was the first time I was like, oh, this is doing something. Like, my headaches started to be milder. I was more aware of like the ability to move my head side to side, and it was the first time that I was like, this is clearly direct relief without, directly injecting those nerves.
Mm-hmm. And the reason why I would say he started feeling relief after the third visit is because we did start by identifying the line of tension or the line of fascia that is infected in his case. And it took me 2 to 3 visits to be able to figure out exactly which line is affected, because the difference between just a regular manual therapy or just go ahead and treat the most painful points and the fascial manipulation by Stecco is to be able to truly identify which line of tension is affected. And so it took me 2 visits to figure out this line. And so like Nick said, after we found out the line of tension, that the fascial line that is affected, we were able to continue all the points starting from the head all the way down towards the lower back. And up until now, how are you feeling now, Nick? Can you describe?
Now it's like I never had a concussion. It feels I haven't had a major headache in feels like a long time now.
Mhm.
Um, and at most, it's a little, I can feel like the soreness coming back, but you've showed me enough stretching and stuff that I can get away with kind of fixing it on my own, or as I can come back and visit you for, one little
Right.
tune up and I'm, back on my feet to pre-2018 head injury.
Yeah, yeah, yeah. And so that was also very interesting how it was a reversible, uh, the points can go back to their original states, which means that uh, working on this hyaluronic acid and restoring the glide between the fascia is reversible. It's not a fibrosis just yet, but it was more a adhesion that we're able to restore the gliding of it. And so that's why you don't have any symptoms anymore. Or if you still do, maybe the points are back, maybe you still have some adhesion that we can actually treat right away, and then you'll feel much better. And so, again, that's the difference between the fascial manipulation and traditional physical therapy, which is also very good, but prescribing exercises right on without release or, working on the fascia can not sometimes is not very successful. So this is Nick had 13 sessions in total. The first 5 sessions were twice a week, and then we moved to and then we moved to once a week for 3 sessions, and then we started spacing out the sessions. The last two sessions were after 8 months of the injury, so it was. I was very happy that I was able to help you, Nick, and it was a very successful treatment. And so here I can show you the line that I worked on, this yellow line and the green line in the back. And it is very similar to Nick's radiating pain. And so this is fascial manipulation that I was talking about. And we can see that is a complete continuous line from from the head all the way down towards the toes. And so these are my references that I use. They're all from the Stecco model. I'm going to go ahead and, oops. Stop sharing my screen, and Dr. Bernstein, there you go.
Thank you. So thank you. Dr. Luthar asked me to just talk about different types of headaches, not migraines specifically. So I'm going to go through 3 different types. You already saw my disclosures. So basically, I think the question is, how do we diagnose headache? And we go pretty much by what's called the ICHD-3 beta criteria, the International Classification of Headache Disorders, and they're quite pedantic in the way that they're written, as you're about to see. But they are the evidenced criteria at this point for making these diagnoses, and there are specific characteristics for various types of headaches. And as I said, I'll explain 3 of them to you today. So the first question for us is always, is the headache primary or secondary? And so primary is just that, right? So it's a rule-out diagnosis. You have to look for other causes of the headache. Migraine, for example, would be considered a primary headache. Tension type headache, which I will talk about, is also considered a primary headache. Secondary headaches come from some specific, usually identifiable cause. So external causes for headache could be trauma. We've just heard about a post-traumatic headache. Could be a brain tumor, which can cause a headache by taking up space right in the closed cranial vault. Other kind of focal lesion like an aneurysm, an AVM. Certain kinds of substances can cause headaches, nitrous oxide, other substances that people might be exposed to. And then infections, think of like meningitis, for example. COVID, as some of you may have experienced, unfortunately, and seen with patients, can cause a headache. And so the list goes on and on. There are 142 pages in the International classification guideline of different types of headaches. And there's an appendix that seems to get longer and longer, as it should, as more headache etiologies are fleshed out. So, post-concussive headache, I am going to go over this specifically, even though, as I said, it is kind of pedantic, but just for clarity. So, it's a headache of more than 3 months duration caused by traumatic injury to the head. And I will tell you that in the headache world, when you use the term chronic, that means that it's gone on for at least 3 months. So people sometimes are diagnosed with a chronic headache. It may have been a shorter time than that, may have been a longer time, but the word chronic has very specific meaning to me and other people who other clinicians who treat headaches specifically. So then there are all these different criteria, and it's written in this way that I think is a little hard to digest. But basically, look at this: the traumatic injury to the head has occurred. Okay, that's a non-starter. The headache is reported to have developed within 7 days after one of the following: either the injury to the head, regaining consciousness after the injury to the head. So that would be somebody with severe head trauma. They don't know if they have a headache if they're unconscious, but once they recover consciousness, they have that headache. Or discontinuation of medicine or medicines that have impaired the ability to sense or report the headache following the injury to the head. Like I said, kind of pedantic. But so that might be somebody, let's say, who's been on an opiate, on an anti-inflammatory. When you stop or taper the drug, the headache begins to present itself and is very obvious. Like I said, greater than 3 months after the onset. Pretty much every single one of these diagnostic criteria include this disclaimer: not better accounted for by something else. Okay, so traumatic injury to the head, we just heard this definition, but again, structural functional injury resulting from action of external forces on the head, impact between the head and an object, or penetration of the head by a foreign body, or forces generated from blasts or explosions. And there's some really interesting research going on in the traumatic head injury unit at Boston Medical Center, looking at blast injury, explosion injury. So when something doesn't necessarily touch the head specifically, but causes this kind of force, exploring what's gone on within the brain with that. Lee Goldstein's doing that work. It's fascinating for anyone who's interested. And then other forces yet to be defined. And then look at this one: when a headache following head injury becomes persistent, the possibility of medication overuse headache needs to be considered. And that's when somebody gets a headache, right? So we talk about this in the headache world a lot. What happens when pain begins to chronify? So sometimes the initial injury may actually improve, but somebody has been taking a medication, let's say ibuprofen, round the clock consistently for such a long period of time that when they try to withdraw or decrease that medication, they get a headache that's just basically a withdrawal headache, and that can be hard to treat. But that is something to consider. All the numbers like 8.2 and everything else, those are just the diagnostic numbers for coding. So this is interesting to me, and I was going back through this, thinking about this talk. So this stipulation that the headache has to have been developed within 7 days, either of the event or recovering consciousness or stopping medications, is somewhat arbitrary. And there are questions again within the headache world about persistent headache attributed to traumatic injury to the head. Causation is more clear, but may lose some sensitivity in understanding what's going on. There may be a delayed onset headache. So somebody may have had an injury, a couple of weeks ago, a couple of months ago, and it's presenting itself, beginning to worsen. And I think this is also part of really good history taking when seeing somebody. Did you have any head injury? You've got this new headache. Could something have happened a month ago? Did something fall on your head? Biggest thing that I see in the clinic for a head injury are the people who are trying to fix the kitchen sink. They're in the cabinet under the sink. They forget that they're there. They stand up and they whack their head. And, they end up with a headache a few days later, wait a while to get in for a headache visit. And finally, they're seen. And it's hard sometimes to figure out causality. So again, trying to really get a good history is important. So look at this down here. To be consistent with this criteria for chronic post-traumatic headache in the time interval 3 months, as I said earlier, is the time after which headache attributed to trauma or injury is considered persistent. So sometimes people get a head injury, somebody playing sports, let's say, soccer ball, they head the ball, they have a headache, but it's gone in a couple of weeks of rest and hydration, and they don't really need any further treatment. But clearly, there needs to be more research going on to understand the intervals of making this diagnosis. So cervicogenic headache is type 2, and I told you I have 3 that I'm going to just run through here for you. And this one is a headache caused by a disorder of the cervical spine and its component bony disc or soft tissue elements, usually but not invariably accompanied by neck pain. There's nothing about this related to any kind of trauma necessarily. So you have to have either clinical or imaging evidence of a disorder or lesion in the spine, soft tissues of the neck known to be able to cause headache, and causation. Headache, this is, I think, also hard to tease out. Headache is developed in temporal relation to the onset of the cervical disorder or appearance of the lesion. You know, I mean, if somebody's got some ongoing degenerative arthritis, how do you know when it started? I mean, that's hard, but again, a little bit vague here. Here's the important one. Look at number 2. Headache has significantly improved or resolved in parallel with improvement or resolution of the cervical disorder or lesion. So let's say that the person got some excellent treatment with Dr. Hudson, for example, for cervical spine, cervicogenic headache, and or one of our wonderful Osher Center chiropractors, and the headache has improved. That may be a cervicogenic headache, or somebody, let's say, who's had surgery, the headache has really improved afterwards. Number 3, cervical range of motion is reduced. Headache is made worse by provocative maneuvers. I will say, and I think we all on this call know, if somebody's got disease in their neck, you don't really want to do provocative maneuvers because that could end up very badly. Or the headache is abolished following a diagnostic blockade of whatever nerve distribution is causing the headache. And then again, I told you this shows up in everything not accounted for by something else. So I just put this picture in just as a reminder for all of us. So imaging findings in the C-spine are pretty common in patients without headache. They're suggestive, but they're not firm evidence of causation. I see a lot of people who have this, you know, in neurology parlance, we sometimes call it a washboard spine, right? So here's the spine, and you can see how it's really indented by discs and other cervical structures. This person may be completely asymptomatic. This may have developed over many years and likely did. And let's say that if I saw this on a patient and didn't think that, you know, we're related specifically, this is something that I would follow over time. And I would say to this person, please don't go skydiving, bungee jumping, or mountain biking. Don't do something where you can fall and really torque your neck, because then you could be in trouble. On the other hand, if we did those things and fell on our neck, we could all be in trouble, regardless of whether our C-spine looked like this. So tension type headache is a primary headache. So it's different than cervicogenic headache. And I want you to think about the 3 rules, applying to this according to the circumstances. So tension type headache, the old name for this was a lot better. We used to call it a hat band headache, right? So it was a band that went around the head. The term tension headache, people will often think that it means that they're tense. It doesn't. It applies more to musculature. But when it occurs for the first time closely with something else that can cause headaches or other causation criteria, the new headache is coded differently according to the causative disorder. So let's say that somebody had a history of tension type headache for years. I mean, we've all had tension type headaches, right? You have a tough day at work, you're leaning over, you're staring at your screen, you have a headache, it's not throbbing, it's not a migraine, but then all of a sudden you get a concussion on top of that. And that's what causes you to present for medical attention. The concussive related headache would be the primary, and this would be the secondary, is what that's saying. When a pre-existing tension type headache can become chronic in a situation where there is something causative, both diagnoses are given. And when a pre-existing tension type headache is made worse, and they use this twofold or greater increase in frequency or severity, it's hard to classify pain. We all know that. But in close temporal relation to causative disorder, both the initial diagnosis and the secondary diagnosis should be given. So there's good evidence, if there is, that the secondary disorder can cause headache. And what all of this is saying is that tension headaches are really common. And when something changes or is different, you need to look for and elicit a history and do an evaluation for a secondary cause. So chronic tension type headaches, at least 15 days a month for about 3 months or longer, they can last hours to days. And this is what I want you to remember. These are really different. They're bilateral. They're pressing pain or tightening pain, mild to moderate intensity. People can usually do their work. They don't get worse the way migraines do when people walk or climb stairs. You don't have a lot of other symptoms like photophobia or nausea, not accounted for by something different. And the exact mechanism of this isn't known. There may be some peripheral pain mechanisms, infrequent and frequent, and central pain mechanisms may play more of a role in the chronic tension type headache. So remember, I was talking about chronification and how complicated it is to tease that out. And so the pericranial tenderness is really important to evaluate in your exam, as Dr. Luthar mentioned. Tension headache can present between times. You can have pain even when you're not having a bad headache. The pericranial tenderness is worse when someone's experiencing the headache. And you can do manual palpation, and there are some measures, there are some guides, there's actually a device where you can measure. So I guess in summary, I want to leave time here for questions. I think I'm good. Ask the questions of the patients. Did something trigger your headache? When did you first notice it? What are the characteristics of it? How long has it lasted? And then, is it a primary headache or a secondary headache? What treatment is the most appropriate with the pain? And I think, as we heard from Nick, thank you for being present in this, drugs are not always the answer. And often they're not the whole answer, and they may not be any of the answer. So it's really important to think broadly.
Thank you, Dr. Bernstein. So let me share my screen again for the last few slides. Oops. And just to wrap everything up, we've gotten a lot of good information from Nick as a patient, from Dr. Bernstein on these nuances of overlapping Venn diagrams of headaches, and from Dr. Hudson on some of the fascial-based treatments in theory that worked in Nick's case. So I want us to all think about, when a patient has a chronic pain syndrome or, say, chronic headache, beyond medications, really think about the physical structures that are impacting the person. Think about myofascial dysfunction. And obviously, we need to rule out any secondary cause before labeling something a migraine or primary headache. In Nick's case, he'd come to me after 5 years of investigation. He had plenty of CT scans and MRIs, and all of those were benign, so I didn't really focus much on that. And just always examine your patients. I know we do a lot of telemedicine these days, but you can learn so much from just putting your hands on and seeing what's actually happening with the tissue. Just references, and we'll open it up now for questions. Here's our contact information for the three of us for questions beyond the presentation. And I'll give it over to Tarana for the question and answer portion.
Great. Yeah. Thank you again to Dr. Luthar, Dr. Hudson, Dr. Bernstein, and again, a special thanks to Nick. And maybe we can unshare and then put everyone up, spotlight everyone here. So as everyone's sort of kind of entering our panel here, let me just start off a couple of questions. This is a wonderful discussion and leads. So first question, I'll pose it to Dr. Hudson, is, in terms of the approach that you're taking, there was an audience, I'm going to kind of broaden the question that the one audience member asked was, how does this approach compare or contrast with some of the approaches that are seen in other systems of medicine, like in traditional Chinese medicine or in Ayurvedic medicine, where you have sort of this combination of finding sort of identifying points or tender points and manipulating the point? And are there parallels that you draw, or are there distinctions that are important to acknowledge here?
Yeah, so it is very interesting. Great question, because the fascial lines that I was talking about they go in parallel to the meridians of in acupuncture and traditional Chinese medicine. And so there's definitely some similarities between the manual therapy that I used and needling or doing acupuncture along the meridians. And so in this case, it was the fascial manipulation as this therapeutic modality. It actually combines, let's say, both Western and Eastern medicine in a way, because we're not only treating locally, but we're treating distally, just like acupuncture. And so I don't know if that answers the question here, but that's what I can say.
Okay. And maybe more to be sort of uncovered in terms of understanding differences too. Again, so which sort of is a segue to another question that was in the audience. JLS is to you for sort of the conventional practitioners that are out there. How do you make a decision? And I'll also turn this to Dr. Bernstein as well. How do you make a decision as to someone with myofascial dysfunction? How do you send them to a craniosacral therapist or a chiropractic care provider or a massage therapist? Like, in which way are you making the distinction? And for you, for both of you, and then maybe Nick, from your perspective as a patient, I suspect that you may have tried other modalities, and what did you learn from your experiences there? So maybe starting Dr. Luther, then Dr. Bernstein, then I'll turn it to Nick.
Yeah, it's a good question. A big piece of it comes down to who are the practitioners I know who have a high level of skill in whatever field they're doing, and does that match with the condition that I think the patient has? And so with Nick, seeing how much was a combination of neck and referred pain, somebody who's both a physical therapist and does myofascial work makes sense because there's not just fascial work, there's also the rehabilitation of the neck musculature and the range of motion. So it's basically taking together the history, the physical examination, and thinking, okay, what would really address the totality of what's going on? And then for his case, it seemed like Dr. Hudson was the right choice, and thankfully it was because Nick is now relieved of his pain.
Dr. Bernstein, your thoughts?
That's such a great question. And it comes up all the time. It's something in integrative neurology. We're talking about what's a rubric that we can use for how to make a decision, who would be the best, or what type of treatment is going to comport best for the patient. And I think Dr. Luther expressed it really well. It's understanding what the symptoms are that are, most that are really disrupting the patient's life. What does the patient want their care to look like? How should we shape it? Knowing practitioners and really appreciating who can deliver the kind of care that we're looking for. But I think, in terms of a really clear roadmap, if somebody has X, Y, and Z, they should go see Dr. Hudson. Specifically, I think we drowned Dr. Hudson's practice, number one. And number two, I just don't think it's possible to do that. So I think conferences like this are really the essence of it, being able to talk about someone's situation with that person present. So again, thank you to Nick for being there. Hear what your experience was like, how Dr. Luther made the decision and found the best person to treat, and then hearing Dr. Hudson describe her treatment. I think the more that we do this, the better we will all get at delivering the most appropriate care to people and helping them feel better.
And Nick, your experience as you imagine you traversed the integrative health system potentially through before.
Yeah, I think that one, it comes down to when you suffer this kind of pain, like you're willing to kind of try as many things as there's possibly out there. And when you start to experience, like when I first went and saw Dr. Hudson was the first time that I was able to actually tangibly feel like, oh, this is like working. Like I feel the pain, then I feel the relief, then I can follow it, as opposed to like physical therapy for my case where it was like I'm doing stuff, but I'm not feeling uh, tangible relief, nor am I getting it explained to me of like what I'm actually feeling. And I think that's a big one is when your provider can actually pinpoint a spot on you, and you are able to say, oh, like this hurts, but you're poking me in my chest, but I'm feeling it in my arm. Like, can you explain what that is instead of saying, oh, like you have like attention, like actually explaining like this is what we're doing, this is why you're feeling it, and watch what happens. Like it becomes like a learning experience for everyone. And I think that just provides, even if it say isn't um, the right answer for that patient, it gives them some insight to be like, okay, I now have this tool to go and talk to my next provider of this is what I experienced and this was explained to me. So you're not just a wheel in the cog or a cog in the wheel. You're actually taking control of your own care and learning along the way.
Thank you. No, I appreciate it. We have so many questions here, so I'm just trying to do my best to get. So, Dr. Hudson, if you can just briefly state, there were a couple of questions on just the method you use and what do you actually feel or sense as you figure out the line using the Stecco method, and what does it feel like when it's released? Like, what is the actual thing that you're looking for? Yeah.
Yeah, so I definitely, it's both me and the patient, we both feel the release. And so at first, identifying the points, it's basically the point is very tender to the touch. It feels crunchy. It's as if something is crunchy under the tissue or like something is not very smooth, as opposed to treating a point that is healthy or that is smooth, there's no pain there. And then the patient would actually guide me because I would ask whether the point is painful or not and whether the point is radiating or not. And so a point that radiates to the painful area, it is a point that is, let's say, we call it densified, or there is some adhesion between the fascial layers. And so this is how I identify the points and follow along the line. And once I start treating, it takes a minute or more to feel the release. And the patient doesn't feel the pain anymore. The radiating pain goes away. And if it doesn't, then we actually go above or below that point because this is where we try and go distally and not just locally.
Thank you. And then just one, and there are many questions. I encourage you, the audience, to reach out to the to our speakers. But one final question, maybe to briefly to Dr. Luthar and Dr. Bernstein, the role of imaging here is always, brought up, and where do you, when and where and how should it, when and where should it be done, in terms of like helping to understand some of the processes here. So I'll start with Dr. Bernstein, then Dr. Luthar. Yeah.
So again, in headache parlance, we talk about new and different, or first and worst. And for somebody who's had a long duration headache pattern, who has a completely normal neurologic exam and no red flag symptoms, we probably would not image at that point. If there were anything that was different, if the headache suddenly got worse, I'm just speaking in kind of broad terms. If I were seeing somebody for the first time who, let's say, never had headaches before, had had some kind of head injury and was really pretty incapacitated, then I would image at that point. And acutely, so seeing somebody in the emergency room after a head trauma, we're going to get a CAT scan because it's the best way to look for acute blood. But after that, after that immediate period, we'd probably do an MRI scan, just because it's more specific for picking up older blood products at different stages, and it is better able to look at the posterior fossa, better able to see small amounts of blood, let's say along the dura, a little bit of subarachnoid bleeding or even subdural bleeding. But in a situation where somebody had a long duration headache with ebbs and flows and a well done neurologic exam, it would not be indicated.
Okay. And I'm going to actually just take appreciate exactly what you said. And Jay, I know you had highlighted sort of taking a good history and physical exam is really the key, even from the integrative approach. I know we're right at time. And again, thank you to our speakers here for participating in an amazing discussion. Really, truly appreciate all of your contributions, and a special thanks to Nick for taking part. I just want to share just a quick final slides. Just as a reminder, next month, please come again. We have an amazing topic research presentation on integrating whole person care, a mindfulness-based model for Parkinson's disease and caregiving. So again, we invite you to attend. There's the QR code. Same time from 8 to 9 a.m. US Eastern time. and we see you on February 4th. And then last and certainly not least, we encourage you to make us support the Osher Center for Integrative Health. As you know, we run these grand rounds. The network forum that some of you may have attended is up online now. So please go to our website. We have an upcoming Tai Chi conference being planned. We have courses in the clinic, and then obviously research programming and planetary health programming. So again, thank you to everyone for being here this morning. Thank you to our audience for a robust set of questions. And again, all of this will be online on the Osher Center website in a couple of weeks, so that you can also access this offline as well. So, and we'll have the contact information or the ability to contact us. But if in the meantime, you can always contact the Osher Center, and we can forward the questions to our speakers. So thank you, everyone. Wishing a wonderful morning, and we will see you next time.